Hello, I'm Dr. Adam Harris. Thank you for your interest in hip replacement with less invasive techniques. The purpose of this film today is to go over what you can expect, what I plan to do, and how you can help prepare for the hip replacement. Also, the video is designed to answer frequently asked questions and also be sure that I tell you everything that I want every patient having hip replacement to hear. So where do we start? We start with, why do a hip replacement? Well, hip replacement is a treatment for end-stage arthritis. Arthritis comes in many forms, but what's common to all forms of arthritis is loss of the articular cartilage or the surface on the joint. Now, the surface on the joint is also the white stuff you see on the end of the chicken bone. But this articular cartilage in a normal, healthy joint has a coefficient of friction that is 1/5 that of ice on ice. When you lose the cartilage and you end up rubbing bone against bone, then it's much more like two pieces of sandpaper rubbing together, and that hurts. So regardless of what form of arthritis gets you there, once all the cartilage is gone, it matters a little less how it got there. Now we talk about how to treat it. So total hip replacement is a replacement of both the ball and the socket. Now, an ideal hip has a round ball in a round socket. Now, if there's anybody out there who's got a perfectly round femoral head, they've never come to see me. Everybody has a head that's a little bit out of round, and depending upon how much you grew shortly before you stopped growing, sometimes it's only a little bit out of round, sometimes it's a lot out of round. And so you end up with an oval in a round socket. And so most of the arthritis that I see in this office comes from repetitively trying to squeeze the larger dimension of the oval into a space only designed for the smaller. And eventually the cartilage gets overloaded and it goes away, basically. A total hip replacement puts in a new socket and a new ball, and this time they're both perfectly round. So what sort of symptoms will someone with end-stage arthritis have if they have arthritis in the hip? Well, one will be pain with activities, pain with walking, sometimes pain that wakes you up at night. Also will be limited motion. People will have difficulty getting on their socks and shoes, and some people have adopted assistive devices so that they can get their socks and shoes on, or have a spouse or partner help them every morning. The loss of motion comes about by two mechanisms. One, when you have the bone on bone, it's just harder to get to certain positions. When you lose cartilage, the joint becomes a little sloppy, but the body doesn't like slop, so it lays down extra bone so as to get rid of the slop. But that extra bone limits motion, and that's perceived as difficulty with shoes, difficulty getting in and out of cars, and sometimes roll over at night and you'll hit the extreme of motion, and that hurts and might wake you up. When you have end-stage or nearly end-stage arthritis, what are the treatment options? Well, technically they range from live with it to replace it. If live with it were a good option, you probably wouldn't be watching this film today. On the other end of the spectrum is hip replacement. Now, in between, there are basically 4 categories of non-surgical management for arthritic joints, only some of which apply to hips. So there are injections, braces, pills, and exercises. Once you hit bone on bone, injections actually are more likely to cause trouble than to do a great deal of good. And I don't care whether we're talking about steroids or stem cells. When it's advanced arthritis, but it's not quite end stage, then sometimes injections are a good way to at least temporize the symptoms of someone with significant osteoarthritis. You can't really brace the hip. You can brace the knee and the shoulder, but you can't brace the hip. When you talk about pills, we talk about Tylenol and anti-inflammatories, things like Advil or Aleve over the counter, or many different prescription medications. As far as exercises are concerned, there are 2 different things to talk about. Number one, as you lose motion and you're trying to do exercises, try to keep the motion that you have. Don't try and get back motion that you've lost. Doing that actually accelerates the process of arthritis and make you come to surgical treatment sooner. The other issue with exercise is weight. Most of us are carrying a little bit of extra weight. The hip sees 3 to 5 times body weight every step you take. And so if you've got more body weight than the average, if you can diminish that in some fashion, then the hip will hurt less. But now let's talk about if the non-surgical things don't work. The time to think seriously about hip replacement is when simple things don't work and the joint is starting to run your life. You don't wait until it's taken over your life, because then the rehab may become much more difficult. The basics of a total hip replacement is that I replace both the socket and the femoral head, or the ball of the femur, with artificial parts. And then you have a bearing of 2 parts that have no nerves in them, and that allows you to restore motion and to relieve the discomfort associated with it. So this is a model of a hip replacement. This plastic here is designed to represent the pelvis, and for orientation, this is what some people refer to as the hip, or the belt line, really. This is the middle of the body in front. Back here would be where the sacrum meets the pelvis. So also some people call this structure out here the hip. This is the greater trochanter, which is the bump on the side of the leg near the hip joint. So what you see here, I'm going to back it up just a little bit, is a round ball and a round socket. Now if we take this apart, what I've done, or what's done in the model here, is the socket is implanted into the pelvis, and a stem is implanted into the femur, and then you put them together and you have a new hip replacement. Now, these are some actual parts. They come in different sizes to fit different anatomy, and they also come in a few different shapes. But this is the style that I use most often. This is the femoral head that is made out of oxinium, so it's a ceramic-like surface. And then on the pelvis side, this is a cup. This gets placed into the pelvis. There are holes here for screws, and this is a bone ingrowth surface. The screws will hold the component in position until the bone is grown in. After that, they don't serve any purpose. They're hidden inside the bone, but it's kind of a pain in the rear end to go and take them out. And then this is a very fancy plastic liner that fits in there, and the whole thing goes together like that. So the expectation after total hip replacement is that you will have markedly less pain, frequently none, and much greater capacity to participate in activities of daily living and athletic activities. Any discussion about a surgical procedure also should include some discussion about what are the potential risks. Well, the potential risks, if you were to list anything that can go wrong, that can be a long list. But most of the risks are very, very small and unlikely. The serious risks that can be associated with hip replacement, one would be infection. My own personal rate of infection for total hip replacement is somewhere around 0.1%, or about 1/3 of the national average. Another potential issue is dislocation. My rate of dislocation is just over 0.1%. I have 3 in about 2,500 patients, and none in the last several hundred. So that's a very low risk. So both of these complications could require additional surgery, again, unlikely. One other potential risk of hip replacement surgery, regardless of the approach, is damage to nearby nerves. Now, with the traditional approaches, the nerve at greatest risk is the sciatic nerve, and with a measurable frequency, people with traditional approaches end up with a foot drop or damage to the sciatic nerve, making the foot weak. The nerve closest to the dissection with the direct anterior approach is the femoral nerve, and that supplies power to the quadriceps. Issues with the femoral nerve after the surgery are few and far between. Never going to say it's 0, but it's less than 0.1%. Having said that, though, there also is a small sensory nerve that's near the area of dissection. The name of this nerve is the lateral femoral cutaneous nerve. And there are times when doing the procedure and pulling the muscles to the side, no matter how much you protect the nerve, it can get stretched. And if it gets stretched, then you end up with a patch of numbness on the side of the thigh. That usually resolves. About half of them resolve within 6 weeks, and the other half resolve within about a year. Now, how the hip replacement is done is important to how rapidly you're able to recover. I have been doing minimally invasive or less invasive surgical replacement of the hip since 2003, and I think I have more direct anterior approaches under my belt than anybody else in the city. Currently, the number is about 2,500. So what is a less invasive approach? Well, I'm going to start by talking about what is a little bit of a joke during orthopedic training. And the joke in orthopedic training is that if brute force doesn't work, you're not using enough of it. That's frequently followed by, well, if it breaks, it needed fixing anyway. The problem with this approach, though, is the more brute force that you need in order to accomplish the goal, the more the patient hurts after the surgery. And so the whole concept of less invasive surgery is first to avoid the use of brute force, and secondly, not to disconnect muscles on the way in so they don't have to be repaired on the way out. The traditional approaches to the hip replacement all detach some muscles which then need to be repaired on the way out and then need to be protected while they heal. If you don't detach any muscle, then you don't have to protect anything. Now, I've been using the direct anterior approach since about 2006 and a very similar related approach, two-incision approach, before that since 2003. The direct anterior approach, the concept is a little bit like trying to look out of a window with Venetian blinds. If the blinds are half closed, you can put your hand in between the blinds, spread them apart, and see perfectly well. Then when you take your hand out, the blinds go back to their natural position and they're unharmed. The difference, of course, is I do this with muscles so that I put my instruments between two muscles, pull them to the side, do the surgery, and then take the instruments out and allow the muscles to fall back to their natural position. As a result of this, most people wake up from the surgery sore rather than really in pain. Of course, there are a handful of exceptions, but the vast majority of people wake up with very little or no pain after the surgery. Most people will walk the same day of the surgery and go home either that afternoon or the next morning. Now, I will want you to walk with crutches or a walker right off the bat until your muscles get used to the new hip. You're not allowed to fall. So you use the crutches, the walker, only as long as you need to until you're confident that you're not going to fall. And for most people, that's a day, 2 days, 3 days, really short periods of time. A simple directive about how to know it's time to get rid of the supportive devices is if you can carry the supportive device all the way around your house, then you can carry it to a corner, put it down, and you're done. I do not like people progressing to a cane. Once you get on a cane is asymmetric, and it's very hard to get out of the habit of using a cane if you get started. I'd much rather you use the walker or crutches for a little longer and then go from there to nothing. Another difference between traditional approaches to the hip replacement and the tissue-sparing approach is that unless there's a specific issue during your surgery, you'll be able to bear weight as you tolerate it right away. And most people can tolerate near full weight bearing right off the bat. Some of the other physicians who do not do direct anterior approach will point to a couple of studies that suggest that fracture is more common during surgery with the direct anterior approach. And to some extent that's true for the new doctor. 2,500 cases under my belt, fractures are few and far between, and most of them are minor such that they do not affect post-operative management, post-operative pain, post-operative activity. Now I want to try and address ahead of time some of the frequently asked questions. Probably the most commonly asked question I get is, when can I drive? The problem with answering this is that there is no good scientific data about when is it safe to drive after hip replacement or knee replacement. What studies are out there suggest that it doesn't matter whether it's right side or left side, hip or knee. Now, many of these studies are relatively primitive and they look only at reaction times. And there's a lot more to driving and driving safely than reaction times. On the flip side of this, if you think about it, right now there are probably a whole bunch of people on the street driving that have no business being on the road, and they didn't just have a hip or knee replacement. So there's a consensus among arthroplasty surgeons. At the present time, it's about 4 weeks. Now, do a lot of my patients drive in less than 4 weeks? Absolutely. I have at least one patient that I know of that walked out of the hospital, got in his car, and drove home the day after the surgery. Now, he didn't get in an accident. But the reason I say 4 weeks is if you choose to drive in less than 4 weeks and something happens, please don't say I gave you permission to do it. Another common question is, how long will it last? Well, here I'm pretty optimistic. The materials that are used in the hip replacement that I select have been bench tested for 30 years of simulated activity. And they've been in people now for about 20 years. And so far, they're living up to their hype. More than 20 years ago, I'd have to tell someone the expected lifespan of the replacement is 10, maybe 15 years if you're lucky. But now, unless there's a specific issue down the line, you can expect 20 to 30 years of good service out of a hip replacement with modern materials. Now, while the implant manufacturers might not like this next statement, there really is not a great deal of difference in the design from one implant to the next to the next. There are a few categories of different designs, and in general, whether you're having surgery with me or having surgery with any other physician, the hip replacement that is selected should be the one with which the surgeon is most comfortable and most familiar. Now, I personally pick a Smith & Nephew implant, and I do it mostly for the materials involved. The current gold standard for materials is a ceramic femoral head in a fancy plastic bearing socket. Now, the Smith & Nephew head is made out of oxinium, which is a ceramic surface on an otherwise metal head, so that one of the key issues with ceramics, which is fragility or brittleness, is completely avoided. Now, modern ceramics, fracture of the ceramic head is rare, but when it does happen, it's quite a disaster. This can't happen with the oxinium femoral head because it's metal, it's not brittle. There's also some slowly growing evidence that the rate of infection in replacements that are done with oxinium as opposed to other metals or ceramic seems to be lower. Not statistical yet, but again, evidence is slowly growing, and I would tend to believe it. Now, some of you may have searched on the internet and seen articles or discussions about alternate bearings. There are basically two other alternate bearings, both of which I'm not particularly fond, and I'll explain why. One of them is ceramic on ceramic, where both the ball and the socket are a ceramic material, and the other is a metal on metal. Now, the ceramic on ceramic has a high incidence of squeaking. If you really want a good laugh, go to the internet and search squeaking hips, and you will find video after video after video of people doing ordinary activities, and you can hear what sounds like a rusty gate as they walk around. I've seen at least one where the patient could produce two different tones and almost play music by moving their hip in different ways. People don't like this. I don't like it. So I don't use ceramic on ceramic. The other bearing is metal on metal. Now I'll briefly give you a history of metal on metal because it's really a bit fun. In the early days of hip replacement, in the 60s, early 60s, Charnley, who was Sir John Charnley, more or less the father of modern hip replacement, developed the low friction arthroplasty, and that was a metal on polyethylene bearing. And the problem with that initially was the polyethylene wasn't that fancy and it wore out, and the bits of debris of plastic caused local problems. Well, around the same time, the Russians with the Sivash and the Americans with the McKee-Farrar developed a metal on metal hip. And most of these were colossal failures. They had a failure rate of 50 or 60% by 5 years. But a handful of them lasted 20 years. And so there was nothing that was put in the early 60s that lasted 20 to 30 years, except some of these people came back for follow-up and their x-rays looked pristine. And so there was another wave of metal on metal with the concept that the early hip replacements failed because of manufacturing techniques which were not that good and now were better. Well, yes, they were better. Only 15% failed at 5 years, and that's an unacceptable number. I think there is a third wave of metal on metal coming. I know where it's coming from, but it's not here yet, so I won't go into any more details. When it does arrive, I'll offer that also to patients. But metal on metal as they exist today, you end up with debris in the joint from wear particles. Like the plastic wears out, the metal wears out. But these have to be cobalt chromium because those are adequate bearing surfaces. But cobalt and chromium are both carcinogens, and they cause all sorts of local soft tissue damage if they accumulate in and around the joint. So this is why the gold standard at the present time in the whole community is a ceramic on fancy plastic, and I prefer a ceramic-like surface, oxinium, to avoid the ceramic issues on, again, the same fancy plastic. I'm frequently asked, how long does the surgery take? Well, when the patient is the one asking me this, I get a little kick out of it because to them, it's going to seem like it's 5 minutes. This is called good anesthesia. It actually takes a little longer than that. On average, the surgery is an hour and a half to 2 hours. This is a custom shop, not an assembly line. Take exactly as much time as necessary to be gentle to the soft tissues and to make sure that everything's right. But that's not the room time. So when your family asks about how long will they be waiting, they also have to have time for the anesthesiologist to do their work, time for the nurses to do their work, and we have to do a prep, get the skin clean, and at the end put bandages on, wake you up, and then get you out of the room. So the total room time, add all these things together, is usually 3 to 3.5 hours. After which time there's at least an hour in recovery room, and then you get back to the floor. And soon after that, you start walking. Now, as far as planning for discharge, this actually starts before you get to the hospital. If you have throw rugs or obstacles or things that might get in the way if you're with crutches or a walker, you want to move them out of the way ahead of time. You want to arrange to have someone to help you out, or arrange to have things delivered to your house as necessary. Now, most people are pretty darn independent very quickly, but don't necessarily count on that. Have backup plans. For example, one patient I recall told me that she was completely independent. She lived by herself. She took care of herself. And when I talked with the family, they whispered, "Mom's a hoarder." So we had to make different plans. Almost everybody goes directly home from the hospital. Only people who really have no support at home or have very complicated home environments need to go to a rehab facility. A good test, so to speak, about when are you safe to go home is consider if there were a fire in your house, could you get your own rear end out of the house? Even if you have a spouse or a significant other or a family member with you, I'm not going to count on them to carry you out. If you can't get your own rear end out of the house, you're not ready to go home from the hospital. Even that having been said, a lot of people are ready to go home the day of the surgery, certainly the day after. One thing that to date has frequently interfered with sending people home the same day has nothing to do with medicine, it's insurance companies. Now, the hospital has to cover the costs that are associated with doing the surgery from their point of view as well. And until recently, some of the insurance companies would only pay the hospital about 1/10 what they would if the patient leaves the same day versus if they leave the next morning. Now, as about 50% of the cost of the hospital stay is the cost of the implant itself, you do that too many times and the hospital doesn't like it very much. So the hospital I go to is a fantastic facility. I don't want them to get mad at me and say, hey, don't bring your cases here, we lose money every time. So I may be asking you, would you mind staying overnight? The other comment here is, in some settings, some other physicians will be forcing people out the door. The hospital I work at is a wonderful hotel. I'm not going to kick you out. But if you have the motivation and the support to leave the same day, it may well be safe to do it. Now, being at home has also many other advantages. Study after study have shown that people who go home use less pain medicine or need less pain medicine. People who go home directly also getting up and getting your own glass of water, getting your own self to the bathroom rather than using a bedside commode, that's therapy. That's returning to normal activities. That's all good. Thank you for your attention. I hope I have answered all your questions and given you good information about hip replacements. I look forward to taking care of you like family, and by the way, I do like my family, and I hope to be soon able to restore your function and minimize your discomfort. Again, thank you.